You want to read it, Carlos?
Case number 3.
Oh, you got it. All right, here's case number 3. Sit.
36-year-old right-handed female referred to your clinic with 4-month history of right shoulder pain and stiffness that has gotten progressively worse. She first experienced this pain fastening her bra. Why would she do it that way? She now specifically complains of pain, especially at night. She is not sure how this started and denies any trauma. Additionally, she has issues cleaning her house, reaching overhead, or reaching behind her back. Past medical history is insignificant except for diabetes mellitus.
Very good. Okay, guys, speak loudly. All right, I don't know how
What
big the phone
is your suspected diagnosis?
Frozen shoulders.
Woo!
Frozen shoulder. Very good.
All right, give us a brief description.
No, it's demographics.
Yeah, demographics.
It's usually women between 40 and 65 years old. It's about 70% more running women.
So, yes, women, 45 to 60-year-old, more so than men. We had good. All right. So, based on this patient's report, there are 2 types of frozen shoulder, correct? Based on the patient report, which one do you think she has? And give us a brief description of both. Which one do you think she has?
Idiopathic.
Idiopathic or primary. Why do you say that?
There's no evidence of trauma or an intrinsic pathology.
So no trauma. The patient comes in and goes, I don't know how it started, I just can't move my shoulder. That's a classic for primary. What is a classic for secondary?
Accident.
Some sort of trauma, or that for some reason they were immobile, right? So it could be part of the trauma, they had a trauma and now they're in a sling, or for some reason they were immobile and therefore they cannot move. Thank you. They get secondary. Good. Explain why their past medical history of diabetes mellitus can be significant, is significant.
Well,
Everyone is going to talk in your group. I love hearing Georgie talk with. Speak loudly, please.
So there's a protein cytokine is present, and it's what it produces an immune response.
So the protein cytokine is present in a patient with diabetes. It prevents it's used for immune response, and there is evidence that correlates cytokines to adhesive capsulitis. So this person has diabetes. So that is another reason why you suspect diabetes. Okay, there are 4 stages of diabetes, not diabetes. Am I missing? Did I forget something?
2 stages.
There's 4 stages of frozen shoulder. So I'm gonna ask you the name of the phase, right? The time period of the phase, and what is a classic symptom of that phase. So whoever's doing it, do it loudly, please. Phase 1 is known as
Pre-freezing.
pre-freezing, and the time period for pre-freezing?
1 to 3 months.
1 to 3 months. And what's a classic example of pre-freezing? What is a classic symptom of pre-freezing?
There's
Pain and external rotation.
Pain and external rotation, and what else?
pain with movement.
Pain with movement, sharp pain with movement, external rotation being the worst. And what about night? Is anything night in there?
Well,
That's a different one.
next
Okay.
stage.
Now, stage 2 is known as what? Freezing. And what is the time limit for the freezing?
3 to 9 months.
3 to 9 months. And it progresses to what? Pain when?
Especially at night.
Especially at night. When you see that patient come in with especially at night, then that is the freezing phase, okay? Next, stage 3 is known as frozen. And what's the months? 9 to 14. And what's the story with this one?
You pull an ice cube on the side of the road. Frozen shoulder.
Frozen.
Yeah.
What's the classic for this one?
The pain decrease.
Yes, pain is starting to decrease. All right, your range of motion, right, is decreased a lot. Your range of motion is really affected, but the pain has gone down. That's classic. And finally, the thawing phase.
12 to 15 months.
And what's classic there?
Decreases especially at night.
So things are much better.
Yeah,
Your range of motion is better, and the pain is decreased. Carlos, When do a patient come into the office with this diagnosis? In the pre-freezing, the freezing, the frozen, or the thawing?
Usually pre-freezing and frozen.
In your clinic, I get nobody pre-freezing. I get after they start feeling some pain, they ignore it.
They cannot
Then they
sleep.
start having more pain at night, they ignore it.
Frozen.
Then in frozen, they
They
cannot
show
move
up.
anymore, and then they're like, oh, damn it, I gotta go to the PT. So it's very rare that you're gonna see a patient in the pre-freezing unless they're really on top of their game. And most New Yorkers are not. That's why calling it inflammation is really a bad thing, because we're past that usually. But that's just where, in my clinic, I usually see frozen. Do not cross this line.
Is ruining the show.
All right, assessment. Very good. Any questions thus far? So the case is clearly primary or idiopathic, frozen shoulder. Good. Where will the patient complain of pain?
Right.
Anterior shoulder, because the anterior shoulder is where most of the pain happens and occurs. All right. What general types of activity will the patient complain of pain with in this patient?
Overhead activities.
Overhead movements,
Cleaning her house.
cleaning her house,
Reaching
reaching behind her back to take her bra off. Good. All right. Now, when we're up to manual muscle testing, again, you will have to know how to perform this. We're not going to do it at this moment. Please go back and go over that with your colleagues. What is the general range of motion deficit?
External rotation.
Okay, and what else?
Primary.
No, not range of motion. Sorry. Go back. Manual muscle weakness. What's weak?
Deltoids. Oh.
Yes, so they have disuse atrophy to their deltoids, which is flexion, abduction, and extension. Very good. Range of motion testing, again, you're gonna have to know how to perform range of motion testing with the goniometer. We're not gonna do it right now. What is the whole range of motion deficit issue and the capsular pattern issue? Loud.
Okay, the capsular pattern is external rotation first.
The capsular pattern is external rotation, go on. What is the capsular pattern?
Abduction.
Arabia, right?
Yeah.
And,
Internal rotation.
but you might not see the capsular pattern with this patient because,
Guarding, stiffening.
right, because if
of
they're in pain and they're not moving, everything's gonna get weak, you're gonna have range of motion deficit. But across the board, what is the number one range of motion deficit? Always external rotation. And after that, it could be any permutation, okay?
Internal rotation is the last one to come back.
What?
Internal rotation is the last one to.
For the capsular pattern, but you might not see that with this diagnosis because they haven't been moving for a while, so they could lack in other ranges. For me, I see a lot of flexion issues, which is not even part of the capsular pattern, but because of this diagnosis, you might see it. Got it? Okay. So again, you have to do the range of motion testing. Special test to rule in your diagnosis. When you have no hair, these things show, okay? A special test to rule in this diagnosis.
Coracoid test.
The coracoid pain test. And remember, do it so that you can show it on the camera.
So there's three spots, three specific spots that you wanna test.
You're palpating 3 specific spots. What's the first spot?
First one will be the AC joint.
The AC joint. How do we find where the AC joint is?
It's like a flat.
No, it's the bump right there. That's the AC joint. And Russ has a very prominent AC joint. That's the AC joint.
it's up here.
That's literally the AC joint. Let's not argue about where the AC joint is on camera.
Okay.
That's where the AC joint is. Very good.
We got time.
You push and you palpate the AC joint. What's next?
So subacromial space,
The subacromial space,
just below that.
which is below the AC joint but above the coracoid process. So it's soft tissue. And finally,
The coracoid process.
and how do we
is
palpate the coracoid process?
Find it. We
You
press.
find it. Yes. You find it. Yes. But get good at finding it. Get good at finding
So
it.
it's-
Right. It's right. It's south of the subacromial, the bottom of the subacromial space.
Right there.
You palpate
Really?
all the,
Here.
and you're not just palpating. You're pushing.
Pushing.
You're
And
bowling for dollars. You're pushing.
this is the one that creates more pain. That's
So
a
all
positive.
3 will be painful, but what will be the most painful?
Coracoid.
The coracoid process will be the most painful. That's a positive sign. Very good. Now, a red flag. Briefly discuss what an aortic aneurysm is. Briefly discuss what an aortic aneurysm is and how it could be associated with shoulder pain.
Aneurysm is bulging of the vessel because of fats, so it becomes weak and it can rupture. Usually that create pain on your chest, and this pain radiates or refer to your shoulder.
Yes, because of plaque, the aorta could rupture, and that's not a good thing. That's an emergency, but you could be mistaken as shoulder pain. So you have to know what that is. Thank you. Finally, treatment. So show us how we'll strengthen the weakened musculature, which is the delts. Show us, let's see.
TheraBand.
We could use a TheraBand. Show us how you'll strengthen your...
So let's do flexion first.
Splendid. Just splendid. Slowly, 90 degrees and down. That's flexion. Good. Show me abduction with a TheraBand. Why not? You got this.
Or you can step on it.
Yes, to 90 degrees and down. Good. Show me extension with a TheraBand. Face the wall. Give us no. Leave it there.
Usually it's like high.
Yeah. There you go. You're starting where? Extension. Not too much because you don't hurt the patient. Very good. Excellent. Now, that was strengthening. Now, this is there's no 1 and 2 mobes for this, because this is a great diagnosis if you have a lot of pent up anger, because you get to work that patient. You force them into new ranges. You do 3 and 4 mobes. If they are not aggressive with this, they will not get better range. Okay? So you're not doing 1s and 2s, you're doing 3s and 4s. And it's whatever direction, right? External rotation is number 1. So what direction do you do the mobes for external rotation? An anterior glide, right? Osteokinematically goes posterior, therefore you do an anterior glide. And if it's, let's say, abduction, what kind of glide would you do? Inferior, okay? Good. And if it's internal rotation? Anterior glide. Again, you have to review and know how to do those glides. But 3s and 4s. Yes, Yad, this is the big leagues. This is the real deal, this class. That's what they told me. All right, now, that's what they told me. Stretching. When you're done with this class, you will have you're gonna go to the clinic and use all this stuff, and you'll impress them. All right, now, stretching.
So,
Show us how to, let's say they have external rotation, abduction, internal rotation. Show us how you will stretch your patient. Good.
Show you or show them?
I don't care. You show them.
So first, external rotation.
External rotation. Patient is supine. Good.
So you're gonna bend your elbow.
Good. You see how you're
I'm gonna
forcing
put
the
a
patient. Yeah.
towel
You're
here.
increasing the range. That's external rotation.
You're gonna bring
Good.
it
Now what about
available
internal
range.
rotation? Excellent. That is getting the patient. But you want to hold on to the anterior so there's no cheating, and show them internal rotation. Good. And now abduction.
Available range.
Very good. That's stretching the stretching. Finally, not finally, but how would the patient do this at home? So how would they do external rotation at home?
External.
Start
So
with
France,
external.
with your left hand and your elbow flex, push into your hand downwards to the floor.
Good. Now show me abduction using the wall as help.
Abduction.
Abduction using the wall. You got them wall walks?
Yes. Spider walk.
Is that what it's for? It must be.
Yeah, you go up.
Yeah, look, we have a wall walk there, but I don't know why. Maybe back in the day there was no fridge there.
Can you
But
use
no, do it here. Do it
Yeah.
Can you
here.
use like a towel
No,
and
yeah,
slide
or just
up?
climb the itsy bitsy spider went up. Now, but as you're going up, go closer, 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 closer. Get it? There you go. Excellent. And what about internal rotation at home? Let's use a towel. Where's the towel? We do not use
Here.
we do not use TheraBands for stretch. Please don't use a TheraBand for stretch. You will not stretch.
Your
Ooh.
right.
Right.
Oh, now go back here. What I like to do is have the patient hold up as high as they can. This arm pulls, pull, pull, pull. Then you fold it over. So now that it's comfortable for
You
them.
keep it there.
And in fact, when I assess a patient, I do, based on what level of the spine they could go up to, So at first, they might only go to L5, and then a few weeks later, they're up to T1. Wow, they're doing much better.
Wow.
Amazing.
Incredible.
All right, now functional exercise. Show us 3 functional exercises that the patient can use. So what are their issues with the donning and doffing the bra? Show it. Look at these functional exercises.
For abduction,
Are you guys ready?
you can don and doff the jacket, but not completely. Just
So let me see it again. Donning and doff. Look. Oh
Okay,
yes.
and
Look. He's doing external
and then put it
rotation.
back.
Internal
Ah.
rotation. I like it. That's
That's
2.
cool.
How about another one for abduction?
Putting away stuff in your cabinet.
Ah, very good. Excellent. That's good. And finally, you decide to do ultrasound on this patient's anterior shoulder, and you want to do deep heating. What do you set the frequency to? 1 or 3? 1 goes deep. Do you do continuous or pulse? Continuous for heat. And then what do you set the intensity to? 1 to 1.5 watts or megahertz. Not watts. Intensity is mega. Yes, that's it. You got it. That's what I expected you to know. Very good.
Woo!
Let's